My name is Keshvi Fichade. I am from final year B physiotherapy, and my topic for rubrics 2 is the pathophysiology and the management of multiple sclerosis. Now, first of all, the definition: multiple sclerosis is a chronic inflammatory demyelinating disease of the central nervous system. Now, what is the demyelination? The myelin sheath is a protective sheath which covers the axons of the neurons. And when that sheet gets disrupted or demyelinated, that is known as demyelination of the central nervous system. Now, introduction: the disrupt ability of the nerves to conduct the electrical impulse, which leads to the symptoms. It generally affect in the younger or the middle-aged patient, the age between 20 to 40 years. Now, pathophysiology: initially triggered by the virus in genetically susceptible individuals. Subsequently, antigen-antibody reaction leads to the demyelination of the axons. Diseases process consists of loss of myelin, then disappearance of the oligodendrocytes and the proliferation of the astrocytes. Changes result in plaque formation, and then there will be a plaque scattered through the central nervous system. Initially, the myelin sheath of the neuron in the brain and the spinal cords are affected. The nerve fiber is not affected. Then the patient may complain of noticeable impairment of the function. Then myelin can regenerate, then the myelin sheath that is present around the axon can regenerate it, then the symptoms are disappeared and resulting in remission. The myelin can be replaced by the glial scar tissue. Without myelin, nerve impulse slow down. With destruction of the impulse are totally blocked, result in permanent loss of nerve function. Now, physiotherapy management, these all are the goals. First is management of sensory deficits, exercise training, management of pain, management of fatigue, management of spasticity, management of coordination and balance deficit, locomotor training, cognitive training, management of speech and swallowing, and functional ability, functional training. Now, first, the management of sensory deficit. Increase awareness of sensory deficit, then the biofeedback. Biofeedback are given to the patient continuously after the exercise. Then proprioceptive loading exercises. Encourage to use the affected side. Encourage the patient to use which side is affected, as the patient to use that side more. Then stroking is given to the patient for the sensations. Then superficial and deep pressures are given. Approximation related to functional tasks. Inflatable pressure splints and safety education program. Then management of pain. Pain relief through regular exercise, massage and ultrasound. Correction of any faulty posture. Then hydrotherapy, the therapy that are given in the water. Then pressure stroking and the gloves. Then stress management techniques, relaxation techniques and meditations. And tense is given. Exercise training, exercise sessions scheduled on alternate days during optimal period. The exercise training are set in the alternate days. Then the sub-maximal intensity exercise prescribed, circuit training, then group exercises and resistance training mode include elastic resistance bands and TheraBand. Exercise with the help of TheraBand are given. Then management of fatigue, energy conservative techniques and the activity pacing. Management of spasticity, training strategies should include activation of the antagonist muscle. For example, if the biceps are agonist, then the triceps are antagonist muscle. Local facilitation techniques can be added to active weak antagonist muscle. It is effective in reducing agonist tone through reciprocal inhibition. Then the elongation of spastic muscles should maintain for 5 to 10 minutes. Then the sustained stretching, positioning and slow rocking. Then ice packs are given for the spasticity, electrical stimulation are given and the vibration to the antagonist muscle are given. Then soothing verbal commands, cognitive relaxation technique. Then for the trunk, rhythmic initiation or the rotation in hook line position. Then proprioceptive neuromuscular facilitation are given and splinting. For improving posture control and functional mobility, rolling, supine to sit and sit to supine, then bridging, then sit to stand and sit down transfers, then then standing, modified plantigrade position, then simple standing and transfers. For improved locomotion, locomotor training, gait training, and orthosis. For locomotor training, body weight support, treadmill activities. The patient should walk on the treadmill. The normal kinematic are promoted. For the gait training, the parallel bar should use. The patient should walk with the help of the parallel bars in front of the mirror. Then ambulation aids, auditory and visual clues to maintain the gait parameters, and dual tasking and NMES. For orthosis, ankle foot orthosis and knee ankle foot orthosis, and wheelchairs are given if the patient can't able to walk. For cognitive training, compensatory strategies of memory deficits, memory by marking a list of things to do and reminders, alarm clocks and bell timers, return direction of functional task, direction posted different areas of home, and mental exercises. Thank you.